Imagine surviving a years-long battle with breast cancer. You've made it through the surgeries, the uncertainty, the immense physical toll, only to find out that the very pill keeping you alive is quietly causing a secondary condition so painful well, it fundamentally destroys your quality of life.
Yeah, and worst of all, nobody really warned you about it.
Exactly. Today, we are unpacking the unspoken aftermath of breast cancer survivorship.
It's a reality that completely shatters the usual expectations of medical recovery. Because usually, you treat a disease and you get better.
Right.
But in the world of oncology survivorship, the diagnostic and treatment landscape is incredibly murky. The very treatments that save a patient's life actively induce a whole new set of profound physical challenges.
Which brings us to the mission of our deep dive today. We are exploring a highly specific, critically important medical intersection managing profound vaginal dryness, or what the medical community calls genitourinary syndrome of menopause, or GSM.
And we're specifically looking at this for hormone receptor-positive breast cancer survivors.
Right. And to set the stakes for you, the listener, we really need to understand the treatment protocol for this specific cancer. These survivors are typically put on adjuvant therapies, drugs like aromatase inhibitors and tamoxifen.
Yeah, and the sole purpose of those drugs is to deliberately, systemically starve the body of estrogen.
Because estrogen is essentially the fuel that could cause their specific cancer to return.
Exactly. That starvation is highly effective for cancer prevention,
Right.
but, and this is the huge caveat, estrogen isn't just a reproductive hormone.
Right, it does a lot more than that.
It's a critical maintenance hormone for the entire genitourinary tract. So when you abruptly shut down the body's estrogen supply, the vaginal tissue goes through severe atrophy.
Just kind of gives up.
Yeah, it thins out, loses its elasticity, and stops producing moisture entirely. And the result is intense, chronic pain, tearing, and a complete disruption of a survivor's intimate life.
And to be very clear about the boundaries of our deep dive today, these specific survivors generally cannot use traditional estrogen-based hormone replacement therapy.
No, absolutely not. Yeah. Giving them estrogen to fix a dryness introduces a very real risk of triggering a cancer recurrence.
So we are analyzing a massive stack of medical guidelines to find out what else is out there. We've got the National Institute for Health and Care Excellence, or NIAS, the British Menopause Society, the American College of Obstetricians and Gynecologists, plus, a slew of clinical trial data and hospital protocols.
It's a lot of material to go through.
It is. And we are synthesizing all of this to answer one vital question. What safe, non-hormonal, prescription-grade tissue protocols actually exist for these patients?
And there are options, which is the good news.
Okay, let's unpack this, because if you are navigating this yourself or helping a loved one figure this out, it can feel like you are entirely out of options. But the sources show the medical frontier is pushing back hard. Let's start with the first tier of clinical defense, which is advanced non-hormonal moisturizers.
Yeah, when we look at the clinical guidelines, the standout molecule here is hyaluronic acid.
Oh, like in skincare.
Exactly like in skincare, but applied differently. We see this extensively in the clinical trials for a product called Hyalofem, specifically the 2020 studies by Carter and the 2022 randomized controlled study by NAPI.
Got it.
But we need to look at the mechanism here because it's crucial to understand why this specific molecule matters over just a standard drugstore lubricant.
Right, because my assumption was always that these moisturizers just act like pouring water on dry, cracked earth. Like, it wets the surface temporarily, but it doesn't really change the dirt.
And that is how traditional lubricants work, yes. But hyaluronic acid is completely different. It's what we call a mucoadhesive molecule.
Mucoadhesive.
Yeah, it physically penetrates the vaginal epithelium, that outer layer of tissue, and it actually induces self-defense mechanisms within the cells themselves.
Wait, really?
Yeah, the research going back to studies by Duzio shows that it stimulates what are called toll-like receptors in the tissue.
Okay, toll-like receptors. Break that down for me.
Think of toll-like receptors as the tissue's microscopic early warning system. Usually they detect pathogens and trigger an immune response.
Okay, makes sense.
But when hyaluronic acid binds to them, it signals the cells to fundamentally alter their environment. It basically commands the tissue to retain massive amounts of water, ramp up cellular repair, and heal microtears.
Oh, wow. So it's active defense, not just passive moisture.
Exactly.
But hold on, I'm looking at these British Menopause Society guidelines, and there's a pretty glaring contradiction here. If these over-the-counter moisturizers and lubricants are completely non-hormonal, why are some of the most famous household brands heavily restricted for breast cancer survivors?
Well, what's fascinating here is the chemistry of the preservatives, rather than the active hydrating ingredients. The British Menopause Society issued a very specific, highly urgent consensus statement regarding parabens.
Parabens, I feel like I see paraben-free on shampoo bottles all the time.
You do. Parabens are incredibly common preservatives used in cosmetics and pharmaceuticals to prevent bacterial growth. But the problem is that parabens possess weak estrogenic activity.
Wait, how does a chemical preservative act like an estrogen hormone?
It comes down to molecular shake,
Yeah.
really. Estrogen receptors in the body are like highly specific docking stations.
Okay.
Parabens have a molecular structure that is just similar enough to estrogen that they can physically fit into those docking stations.
Oh, I see where this is going.
Yeah, when they dock, they trick the cell into thinking actual estrogen is present, and that triggers a weak estrogenic response.
That is wild. So a survivor goes to the pharmacy, buys a tube of something clearly labeled non-hormonal, and might actually be feeding a weak estrogen mimic directly into their bloodstream.
Which is exactly why widely known everyday products that contain parabens brands like KY Jelly, Replens, and Astroglide are specifically flagged in the guidelines.
So they are explicitly told not to use them.
Right. The clinical recommendation is that breast cancer survivors must actively avoid them. The protocol aggressively steers patients toward explicitly paraben-free alternatives to eliminate any chemical that could even remotely interact with an estrogen receptor.
So they need to look for specific brands.
Exactly. The guidelines point patients toward brands like Yesis, Silk, or the hyaluronic acid-based Hyalofame we just talked about.
Okay, so we have a safe topical option. But if we are being realistic about the limitations here, hyaluronic acid requires continuous, ongoing application.
Right. It's not a permanent fix.
It's essentially a high-tech Band-Aid. It doesn't fundamentally change the systemic biological reality that the body's moisture factory is just shut down. If you stop applying it, the dryness comes right back.
Exactly.
And that limitation naturally drives the medical community to look for a systemic, prescription-level solution.
Right. They want something that can wake the tissue up from the inside, which brings us to a specific class of pharmaceuticals known as SERMs.
Here's where it gets really interesting. Because the sources highlight a 60 milligram daily oral pill called ospemifene, which is sold under the brand name Sensio or Osfina.
Yes, that's the one.
But I'm going to stop you right there because I am completely confused. You just established that these patients absolutely categorically cannot have estrogen. The whole point of their grueling cancer treatment is to starve the body of estrogen. So how on earth can an oncologist prescribe a pill that acts like estrogen in the vagina?
I know, it sounds like a total biological paradox, but it comes down to the highly targeted science of a SERM, which stands for Selective Estrogen Receptor Modulator.
Okay, so I'm imagining like a biological double agent, like it's a friend to the vaginal tissue, shaking hands and letting everyone in, but it acts like a hostile bouncer at the door of the breast tissue, keeping estrogen out. Is that accurate?
That is actually a phenomenal way to describe it. In the vaginal mucosa, ospemifene acts as an agonist. It plays the friend.
God.
It promotes estrogen-like effects, which lowers the vaginal pH back to healthy, acidic levels, and it thickens the tissue. Crucially, it improves what we call the vaginal maturation index.
What exactly is that index measuring?
Well, when a patient is starved of estrogen, the vaginal lining thins out so much that it's mostly comprised of basal cells.
Yeah, those are bad.
They're just fragile. They're immature cells that tear easily. The maturation index measures the shift back to superficial cells, which are the durable, mature, healthy cells you want lining the tissue.
So the drug forces that shift.
Exactly. Ospemifene wakes up the factory. But, and this is where your bouncer analogy is perfect, in breast and endometrial tissue, it acts as an antagonist. It actively blocks the estrogen receptors in those areas.
That sounds like the holy grail. A daily pill that fixes the severe dryness internally, but actively blocks the cancer from returning.
You would think so, yes.
But looking through the sources, this drug is actually the center of a massive, ongoing global medical controversy.
It is a profound debate. And we have to look at this impartially, because the global guidelines are completely split down the middle here.
So what's the European stance?
On one side, you have the European Medicines Agency, the EMA. Their guidelines state that ospemifene is a viable prescribed option for these survivors, provided they have fully completed their adjuvant breast cancer treatment.
But on the other side of the ocean,
The U.S. Food and Drug Administration, the FDA, along with the Endocrine Society, strongly advise against its use for breast cancer survivors.
Why the split? I mean, if the science says it acts as a bouncer at the breast tissue, why is the FDA pushing back?
Their argument is rooted in a lack of long-term definitive safety data. The clinical trials that currently exist for osibemitene rely heavily on short-term surrogate markers.
What kind of markers? Like blood tests?
Things like measuring changes in mammographic breast density over a period of a few months. Mammographic density refers to how thick the tissue appears on an X-ray, which heavily correlates with estrogen activity.
Oh, I see.
Yeah, if the density increases, it's a major red flag that estrogen receptors are being stimulated. The short-term data doesn't show an increase, but the FDA argues that breast cancer can take years, even decades, to recur.
Right, it's a long game.
Exactly. Until we have long-term, multi-year data proving conclusively that this double agent doesn't eventually switch sides and unlock a cancer recurrence, the FDA considers the risks simply too high.
So if you are a patient, you are caught in this incredibly frustrating limbo between European guidelines saying it's safe post-treatment and U.S. guidelines saying it's too risky.
It's a really tough spot to be in.
And it makes total sense why so many oncologists and patients just want to avoid systemic pharmaceuticals altogether. If there is even a shadow of a doubt about an estrogen-like pill, they won't touch it. They want a localized physical protocol that repairs the tissue without introducing a single new chemical into the bloodstream.
And that leads us to the most high-tech, non-chemical intervention available in our clinical sources: transvaginal laser therapy.
Lasers.
Yes, we are specifically looking at the use of fractional CO2 and erbium-YAG lasers.
Wait, you're telling me the solution to severely painful, thin, damaged tissue is to intentionally burn it with a laser? That sounds entirely counterintuitive.
I completely understand why it sounds alarming, but the biological principle is actually identical to the laser technology used by dermatologists for severe acne scar removal or deep facial rejuvenation.
Oh, really? Are we basically talking about the same laser technology applied internally?
Pretty much. The protocol typically involves 3 treatment sessions in a clinic, spaced about 30 days apart. The doctor carefully inserts a specialized 360-degree cylindrical probe into the vaginal canal. As it is rotated and slowly withdrawn, it emits microablative thermal energy.
Microablative, meaning it's not burning the entire surface area, right?
Correct. The laser creates microscopic columns of dermal trauma. It essentially pokes thousands of tiny microscopic heat injuries into the vaginal epithelium, leaving the healthy tissue in between those columns entirely intact.
And I'm guessing that intact tissue is what allows it to heal so quickly.
Exactly. This controlled microtrauma forces the body's natural healing cascade to kick into absolute overdrive. It aggressively stimulates fibroblasts.
Fibroblasts, those are essentially the body's microscopic construction workers, right? The cells responsible for laying down new structural scaffolding.
That's spot on. The laser wakes up the fibroblasts and they start producing massive amounts of new collagen, elastin, and extracellular matrix.
So it's basically rebuilding from scratch.
It is. It doesn't just hydrate the tissue temporarily. It fundamentally remodels and regenerates the physical structure of the vaginal wall, making it thick and elastic again, entirely without hormones.
And the clinical data on this is actually staggering. I was reading through the retrospective case studies from Pagano, which involved over 80 breast cancer survivors who had failed to get relief from any other non-estrogen treatment.
The results there were pretty incredible.
They really were. After just 3 cycles of the CO2 laser, they saw massive, measurable improvements in tissue elasticity and moisture. And the EATER study is even more notable because of the timeline.
Right, the follow-up period.
Exactly. They tracked women for 18 months after their 3rd laser treatment, and the women had sustained statistically significant improvement in dryness, itching, and dyspareunia, which is the medical term for severely painful sex.
The clinical satisfaction rates reported across these independent studies are frequently between 80 and 92%. Women are reporting a profound restoration of their quality of life.
But, because there's always a but in oncology.
There always is. This raises an important question about the pace of medical adoption versus regulatory caution. While the individual clinical studies and patient satisfaction rates are overwhelmingly positive, the FDA has issued clear safety warnings regarding the use of energy-based devices, like lasers, for vaginal rejuvenation or the treatment of menopause symptoms.
Are they seeing massive complication rates?
Not necessarily in the published studies, but the FDA's stance is that these devices are officially cleared for specific gynecological surgeries, like destroying precancerous cervical lesions, but they're not explicitly cleared for treating GSM.
So what are they asking for?
The FDA wants much larger, multi-center, randomized controlled trials completed to absolutely rule out the risk of long-term complications like severe scarring or internal burns before giving it an official stamp of approval.
But again, we see this divergence in the medical community because despite the FDA's warning, the National Institute for Health and Care Excellence, NICE in the UK, along with numerous ongoing clinical pathways, continue to explore and utilize transvaginal lasers.
Yeah, for cancer survivors who literally have no other choice, who can't use estrogen, who are warned off SERMs, it becomes a calculated risk management scenario.
Right.
It is entirely about risk versus reward. When the alternative is decades of severe, debilitating daily pain and the complete loss of intimate function, many patients and their doctors view the laser protocols as a deeply necessary, completely acceptable intervention, despite the FDA asking for more long-term data.
But here's the massive blind spot I see in just relying on the tissue treatments. Whether you use a paraben-free hyaluronic acid to hydrate the cells or a fractional CO2 laser to rebuild the collagen scaffolding, that only addresses the physical cellular structure.
That's a really crucial point.
The sources make it very clear that severe long-term dryness causes a cascade of secondary functional and psychological trauma. Fixing the tissue doesn't erase the memory of the pain.
This is perhaps the most critical evolution in the modern standard of care for survivors. The final layer of clinical protocol we see emerging in the recent literature is the mandatory integration of pelvic floor physical therapy and specialized psychological counseling right alongside the tissue treatments.
Because the brain cannot distinguish between cancer treatment side effects and physical trauma, right? It just knows the body is in extreme pain, so it braces for an attack.
Precisely. We have to look at the mechanical mechanism of pain. When a woman experiences severe dyspareunia for months or years due to a lack of estrogen, her body instinctively reacts to guard against that severe pain.
Like a flinch response.
Exactly. This causes involuntary hypertonic spasms of the pelvic floor muscles. The muscles literally lock up in a state of constant rigid tension to protect the area.
So it's like fixing the suspension on a car, but the driver is still slamming the brakes because they expect a crash every time they turn the wheel.
Great analogy.
Even if you use a laser and the vaginal wall is thick, healthy, and elastic again, the muscle memory of the pain remains. The pelvic floor will still involuntarily spasm, causing severe pain, even with healthy tissue.
Exactly. The biological hardware is fixed, but the neurological software is still running a trauma program. Therefore, the newest clinical protocols, like the Phase 5 trials referenced in our sources, mandate a comprehensive, combined approach to retrain the entire nervous system.
What does that physical therapy protocol actually look like in practice?
Well, they prescribe a non-hormonal moisturizer to be used 3 to 5 times a week to maintain the tissue, but they pair it immediately with the use of vaginal dilators under the guidance of a pelvic floor physical therapist.
So they're physically retraining the muscles.
Yes. The physical therapist works to perform internal manual release of the trigger points in those hypertense pelvic floor muscles. They teach the patient down training, which is how to consciously relax a muscle group that has been clenched tight for years.
And the dilators?
Meanwhile, the graduated dilators gently stretch the tissue and help retrain the brain that penetration no longer equals tearing or pain.
And the psychological counseling?
That addresses the profound, often silent psychological impact this condition has on a survivor's body image, their sense of femininity, and their relationship dynamics. You simply cannot treat the estrogen deficiency without treating the psychological footprint it leaves behind.
So what does this all mean? If you are listening to this and you or someone you love is navigating the really tough road of breast cancer survivorship, it means you do not have to just put up with this side effect.
No, absolutely not.
For so long, the medical narrative was just, be glad you survived the cancer, deal with the rest. But the sources show that the landscape has shifted. There is a multi-tiered, highly researched, non-hormonal clinical pathway available to you.
But it is a pathway that heavily requires self-advocacy. You have to ask your oncology team for these specific non-hormonal referrals.
Right. To quickly recap our journey today, we started with the baseline of avoiding parabens and utilizing clinical-grade hyaluronic hydrators that physically stimulate the cellular defense mechanisms.
Then we explored the highly selective biological double-agent science of SERMs like ospemifene and the global debate surrounding them.
Yeah, and we looked at the incredible tissue remodeling, collagen-generating power of fractional lasers. And finally, we saw how all of this must be tied together with functional pelvic floor physical therapy and counseling to treat the nervous system and the whole human being.
If we connect this to the bigger picture, What we are really talking about is a fundamental structural shift in the philosophy of oncology. For decades, the entire focus of cancer treatment was simply eradication.
Eradicate the tumor, keep the patient alive. Full stop.
Exactly. But these emerging protocols represent the realization that surviving breast cancer shouldn't require sacrificing your comfort, your intimacy, or your quality of life. The goal of modern medicine has to be ensuring that survivors don't just live, but that they actually thrive.
Thriving is the goal. And it leaves me with one final, slightly provocative thought to chew on.
Well, let's hear it.
Well, we talked about how fractional lasers use microtrauma to essentially trick the vaginal tissue into regenerating massive amounts of collagen entirely without estrogen. It makes you wonder, could the next frontier be actual bioengineering?
Oh, wow. Like lab-grown tissue.
Yeah. Could we eventually use a patient's own stem cells to grow entirely new non-estrogen-dependent mucosal tissue in a lab and seamlessly graft it for cancer survivors, effectively bypassing the need for controversial pills or lasers entirely?
That would change everything.
It is a fascinating thought for the future of survivorship and a reminder of how fast this science is moving. Thank you so much for joining us on this deep dive. As always, keep questioning, keep advocating for yourselves, and keep exploring. We'll catch you next time.